Thank you. I'd really like to thank Marcia Stefanik and Bev Mitchell for the invitation to speak today and to share some of our work. The main intent of this talk is to review our work on modeling breast cancer metastases in the lab. But because we're talking about sex differences, I wanted to first put on my hat as the director of the Osteoporosis Clinic and highlight and increase awareness about a gender disparity that I think we need to study more about. So there's growing awareness that osteoporosis has a high clinical and economic burden. Half of all women over the age of 50 are expected to fracture in their lifetime. There are about 300,000 hip fractures a year. That's roughly equivalent to the number of MIs. And what's really shocking is the one-year mortality exceeds 20%. So that rivals many advanced stage cancers or congestive heart failure. And this comes with annual costs that exceed probably $20 billion by now. What's less appreciated is that osteoporosis affects men as well. 1/3 of all hip fractures occur in men. Men over the age of 50 are actually more likely to have a fracture than to develop prostate cancer. In the US, the numbers are approximately 600,000 fractures a year in men, of which 75,000 are hip fractures. Despite the fact that men are twice as likely to die after hip fracture, they're only 50% as likely to receive treatment. So we can do better. And this has issues and relevance for cancer survivorship as well. So bone loss is exceedingly common among cancer patients for a variety of reasons that I've highlighted here. Hypogonadism is very common in women because of early menopause, often induced by radiation or chemotherapy, also with aromatase inhibition that's becoming a standard treatment for many hormone-responsive breast cancers. In men, androgen deprivation therapy for prostate cancer is associated with profound bone loss. And then the treatments for cancers, including radiation, chemotherapy, clearly target the skeleton with adverse effects as well. Among those patients whose cancers may be amenable to hematopoietic stem cell transplantation, the effects of transplantation and its immunosuppression following are also very damaging to the skeleton. So treatment with glucocorticoids, immunosuppression, especially cyclosporin, and particularly following bone marrow transplant, the rates of bone loss can be 10 times normal within the first year to two. And finally, you have all the other causes associated with chronic illness, heparin treatment, renal dysfunction, malabsorptive disorders, vitamin D deficiency, and effects of other treatments such as GCSF. So just to raise awareness that bone loss is an important issue and that we need to do better by our male patients. But my focus today is really to talk about the microenvironment in the skeleton and why it's such a frequent site of metastases for many cancers. This is Stephen Paget. Over 125 years ago, he first proposed his seed and soil hypothesis to explain why the skeleton might be such a favorable site for many cancer metastases. We have a slightly improved molecular and cellular understanding these days. First, to review normal bone physiology. The balance of bone mass is largely determined by the interplay between bone formation and bone resorption. So on the formation side, you have osteoblasts that are derived from mesenchymal stem cells. They secrete extracellular matrix, especially type 1 collagen, that's then mineralized by the deposition of calcium and phosphate. On the resorbing side, you have osteoclasts that are of hematopoietic origin, and they break down and degrade the bone, in turn releasing a lot of factors that are stored within the extracellular matrix. And there's close communication between osteoblasts and osteoclasts. This microenvironment, for various reasons, plays host to invading tumor cells. So in this schematic, you can see that tumor cells here shown in blue first arrive via the vasculature. And so there are mechanisms that promote the recruitment and extravasation of tumor cells into the bone marrow microenvironment. And they can actually reside there in a dormant state for many years and can be a site of late metastases. Due to signals that are not entirely well understood, at some point they emerge from dormancy and start to colonize the local bone marrow microenvironment and ultimately can give rise to a full-blown metastatic site. Depending on the types of cancers, you can have tumor cells that stimulate a largely osteoblastic response. So prostate cancer is a good example, in which the factors that are produced by tumor cells preferentially stimulate osteoblasts and therefore bone formation. You can have osteolytic metastases. Breast cancer is a classic example, in which tumor cells secrete factors that preferentially favor osteoclasts and their degradation of bone. Regardless, these interactions lead to what's termed as the vicious cycle, in which tumor cells interact with both osteoblasts and osteoclasts, secreting various factors. These two lineages communicate with each other. Moreover, the release of various factors, especially TGF-beta, from the local microenvironment, then feed back in turn to either recruit and or stimulate proliferation of tumor cells. And this becomes a very difficult cycle to break. As you all know, the skeleton is a very frequent site for cancer metastases, and this is relevant, of course, because by the time cancers have spread to bone, they're generally incurable. So the most common cancers with bone metastases are the following. Among patients who have advanced stage cancer, breast and prostate cancer patients have bone metastases over 70% of the time. Half of advanced thyroid cancers are involving the skeleton. And roughly a third of lung and kidney cancers have targeted the bone. And together, these 5 cancers account for over 80% of bone metastases. 3 of these cancers are also the most common cause of cancer deaths. So lung in both men and women, prostate in men, and breast in women. And so I think here we have real opportunities to study both sex differences and then within gender factors responsible for these high rates. Today I'd like to focus on work that we've been doing in the lab on breast cancer skeletal metastases. As you know, there are almost 250,000 cases a year. Advanced stage disease with spread is incurable, and 70% or more of these patients have skeletal involvement. So the medications that we have at our disposal for treating skeletal involvement of cancer are essentially the same ones that we have available for the treatment of osteoporosis. So in our bone clinic, I often explain to patients that decreased bone mass is usually due to an imbalance between bone formation, which I liken to the bricklayers, and bone resorption, which I draw analogy to the folks with the jackhammers. And with this schema in mind, we really have 2 options for increasing bone mass. We can either block bone resorption with anti-resorptives, or we could try to stimulate new bone formation with anabolic therapy. In osteoporosis, as you'll see also in cancer therapy, by far and away the most common treatments are the anti-resorptives, so blocking bone resorption. And in particular, we have good evidence that 2 of the classes of medications, the bisphosphonates, as well as a newer medication, Denosumab, which targets an osteoclast differentiation factor called rank ligand, these 2 have been used with great effect in patients with advanced cancer and skeletal adverse events. So here's one example of many in breast cancer, showing that zoledronic acid, which is an intravenous bisphosphonate, significantly reduces skeletal adverse events in patients with advanced breast cancer. The total frequency of adverse events is reduced from 50 to 30% among women who are treated once with a 4 milligram dose of zoledronic acid. This might be monthly, once monthly for a year. And you can see that this decreases all sorts of complications. So fractures, need for radiation or surgery, need to perform spinal cord decompression. And so zoledronic acid is very effective at decreasing the frequency of skeletal adverse events in breast cancer. Denosumab is a monoclonal antibody targeted against rank ligand, which is required for osteoclast differentiation. It's a newer medication. And it appears to possibly be even superior to zoledronic acid, which is known to oncologists as Zometa and osteoporosis physicians as reclassed, but they're the same medication. So denosumab decreases the frequency of adverse events significantly in breast cancer, although it does not appear to have any effects on overall survival. So we have 2 very good options for patients with advanced cancers and decreasing their skeletal events. But over the years, I've seen many breast cancer patients and other cancer patients in the clinic, and I've had cause to wonder whether there might also be a role for anabolic therapy as well. And why would I be thinking that? Well, I've already mentioned that osteopenia and osteoporosis are very common among patients, especially with breast cancer, particularly in women who've had chemotherapy-induced menopause at an earlier age than they might otherwise expect to go through menopause. Aromatase inhibitors are very effective at decreasing recurrence rates, but do cause significant bone loss. Bisphosphonates, although very effective, have limitations. In particular, they're associated with rare conditions, osteonecrosis of the jaw or atypical fractures, but especially osteonecrosis of the jaw, 96+% occur in cancer patients, and this can be a very debilitating side effect. It's a trauma of the bone that results in failure to heal. It can be very painful to patients and very disfiguring. Bisphosphonates cannot be used in patients who have decreased renal failure, not an uncommon finding among cancer patients. And finally, they only block resorption and ultimately don't increase bone formation and therefore can never cure osteoporosis. Recombinant parathyroid hormone, also known as teriparatide, sold in the US under the name Forteo, is at the moment the only anabolic approach that we have for osteoporosis. There are other drugs in the pipeline, but for the moment, this is what we have. And here shown two doses, 20 and 40 micrograms, from the publication that led to FDA approval. You can see that Forteo really dramatically and significantly increases bone mineral density, both in the spine and the femoral neck of the hip, and significantly decreases the frequency of fracture rates among patients. Now, for many years, we've come at this problem because my lab has been interested in the role of the bone and osteoblasts in supporting normal hematopoiesis during physiology. We all know that the bone marrow within the bone cavities is the site of hematopoiesis, and probably, like many of you, throughout my clinical training, I just thought that was a safe place for it to happen. But it turns out that actually, if you look carefully at the interactions here along the bone surface, where osteoblasts are lining the surface and forming new bone, there are actually many interactions between osteoblasts and hematopoietic cells, including their stem and progenitor cells and also mature lineages. And it turns out that these interactions are critical for normal hematopoiesis. So this has been an area of great interest to my lab for some time. And just for the sake of time, I've summarized the major ways in which we think of how bone might influence osteoporosis. So osteoblasts and their progenitors can produce cytokines and growth factors that are required for hematopoietic differentiation. Examples of this include CXCL12, IL-7, which is a B-cell differentiation factor, and of course rank ligand, which I've mentioned is an osteoclast factor. It turns out there is abundant cell-to-cell direct contact between osteoblasts and hematopoietic cells. These are often mediated by cell adhesion molecules such as VCAM1 or integrins. And finally, I mentioned that osteoclasts, in breaking down the extracellular matrix, cause release of many factors from that matrix, of which TGF-beta is one of the most common and clearly has effects on tumor growth and proliferation. So we've been interested in the PTH pathway for a long time because PTH, of course, increases bone. But also many years ago, it was noticed that PTH has indirect effects on hematopoiesis. So here is an image from a mouse in which a constitutively mutated form of the receptor that's always active has been targeted to bone. You can see a dramatic increase in the amount of pink trabecular bone here. And it was with great excitement that it was noticed that this led to a doubling of the frequency of hematopoietic stem and progenitor cells within the marrow. So this was really the first evidence that by targeting bone, we could have effects on hematopoiesis. And in fact, at least in mice, PTH can improve the survival of mice given a bone marrow transplant after radiation. So this is an example of how PTH regulates normal hematopoiesis. Now, from many years of study across many labs, it's evident that metastatic cancer cells hijack, if you will, many of the same pathways that are used by hematopoietic cells to communicate with normal bone. So many of the same cell adhesion molecules, The same factors are secreted by tumor cells, and it's thought that that is how they're attracted to osteoblasts and recruited to the bone marrow environment, and how they are able to set up their new home there. For that reason, I've long wondered in the clinic whether it would be safe to give anabolic therapy to patients, in this case with breast cancer, but I think relevant to any cancer. There are complicated reasons on both sides of the argument. Just to summarize them, I think it's very possible that PTH could worsen skeletal metastases because the increase in bone turnover that's stimulated by PTH might actually release more chemoattractants that would cause more tumor cells to home to the bone. On the flip side, it's also possible that, as the case with normal hematopoietic stem cells, if you increase the number of niche sites or make them more favorable to normal hematopoietic stem cells, that they could therefore crowd out and compete away cancer stem cells and prevent their engraftment. It's one of the rare cases I've encountered in the lab where I couldn't come up with a strong argument in favor of one or the other, but I think that it's clinically relevant that we know which one is the case. If it's harmful, then we need to know to advise patients with breast cancer to avoid Forteo at all costs. On the other hand, if it is possibly beneficial, then we introduce another option into the armamentarium for treating bone loss in these patients. And I do need to mention that we have to be very cautious. PTH in rodents is associated with an increase of osteosarcoma. There's no evidence in people that it increases bone cancers, but it is contraindicated in patients who've had skeletal irradiation, and of course that is the case with many breast cancer patients. So we set out to test the hypothesis in mice that anabolic PTH treatment might reduce the frequency of breast cancer metastases. This was work that has largely been done by a wonderful staff scientist in my lab, Srilatha Swami, and we've had the fortune to be funded by the Mary Kay Foundation to do this work. So our first model is to use a model of metastatic breast cancer in mice. We've used bulb-C mice and used a line of murine breast cancer, 4T1 cells that have been modified to express both GFP and luciferase, and for which we're very grateful to Bonnie King for providing these. And these cells were injected directly into the intramammary fat pad to induce a primary breast cancer formation. We first asked whether treatment with PTH could decrease skeletal metastases. And so what we did was we took relatively young mice, started treating them with a standard dose of anabolic PTH, 80 micrograms per kilo per day, and we had a cohort of mice that were just injected with phosphate buffered saline. We treated them for 4 weeks and then injected the 4T1 breast cancer cells into the mammary fat pad to establish a primary breast tumor, continued treatment for 4 weeks, and then euthanized the mice and investigated all their organs for evidence of metastasis. I'm hoping that there would be a frequency of metastasis to the bone. So here's just showing you 5 mice from each group, showing that we can establish a primary breast cancer in all mice, regardless of whether they're treated with PTH or PBS. After 4 weeks, when we look at the internal organs, so these are mice that have been euthanized and then their internal organs dissected out and imaged for the presence of metastatic cancer cells, and looking, for example, in the lungs, the liver, and spleen, we find that these cancer cells do readily metastasize to internal organs, and there's no difference between PTH and PBS-treated animals. However, the first exciting finding was that when we looked in the limbs of these mice, it appears that mice that are treated with PTH both have fewer episodes of metastasis, but also decrease in volume. So these are the numbers. We've treated now 20 mice in each group. There's no difference between the cohorts in metastasis to the internal organs. However, metastases to the hind limb are very significantly reduced by PTH treatment or pretreatment. In addition, when we quantify the luminescence as a surrogate marker for the volume of the tumor, there's no difference in lung, liver, or spleen, but there is a significant reduction in the volume in hind limbs of PTH-treated mice. Now, PTH, our model is that it's acting on the microenvironment, acting on the osteoblasts. But of course, many cell types do express PTH receptor. So we have to consider several possible effects of PTH on the tumor. The first is that there could be a direct effect of PTH on the primary tumor. The second, that it's acting on the microenvironment, as we've hypothesized. And finally, PTH causes changes in serum calcium and vitamin D metabolism. And in particular, David Feldman here at Stanford has been studying for a long time the effects of vitamin D on breast cancer. So these are all factors that we will need to address. First, to show you some evidence that we have on PTH and whether it affects the primary tumor. We've cultured breast cancer cells in culture, and PTH has no effects on the rate of cell growth in culture, and nor does it have any effect on the primary tumor volume in vivo. To look at whether there are direct effects of PTH on the microenvironment, here I'm just reviewing that there are many steps involved in metastasis of cancer, from the primary tumor becoming invaded by blood vessels and then tumor cells escaping into the vasculature and homing to a distant organ. We wanted to bypass all of these steps and just look at the final engraftment and engagement. And so we took a model where we injected the breast cancer cells directly into the tibia so that we could bypass all of the distant steps and just focus on how cancer cells engraft in bone. So this is a similar experiment. We pre-treated with PTH, except this time we've injected the cancer cells directly into the tibial bone marrow compartment and continued treatment. And again, we find a significant reduction in the number of mice that have established bone metastases, as well as the volume of these tumors. This is a log 10 scale, so in the PTH-treated mice, they're actually decreased by between 10 and 100-fold. Marcia, how many minutes? 3, okay. So finally, we wanted to look directly at whether PTH might be impacting the ability of bone cells to recruit cancer cells. And to do that, we've developed a breast cancer migration assay in the lab, largely the work of a wonderful undergraduate, Lance Bentonson. We cultured osteoblasts in culture, treated them with PTH, and then added in a transwell assay either 4T1 murine breast cells or MDA human breast cancer cells, incubated them for a few hours, and then simply counted the number of cells that crossed through and were responding to the osteoblasts. And we've been able to show that PTH decreases the frequency of migration towards osteoblasts, both in 4T1 mouse breast cancer cells and also in a human breast cancer line. We can find that PTH significantly decreases migration. So to summarize, we found that PTH decreases the frequency of breast cancer skeletal metastases, the tumor volume. So far, we've not found effects of PTH on the primary tumor itself or on frequency of metastases to other organs. And we've shown in culture that the migration is decreased towards osteoblasts. We have many exciting directions to go in the future. We're going to do gene expression profiling of both the tumors and the bone marrow niche. We've now started a study to initiate PTH sort of at the time of diagnosis, so at the time that we initiate breast cancer in these mice, which might be more akin to a clinical study. And then we have mice that are lacking PTH signaling in their skeleton so that we can see those effects. So to circle back to the idea of how PTH might be relevant in sex differences in cancer, we're of course very interested in what this might do in other tumor models. To remind you, lung is the #1 bone cause of death in both men and women, and then of course prostate is relevant in men. So anyone who has models of these cancers in mice, we'd be very happy to collaborate. We have some word of caution from studies we've done with leukemia. The bottom line is that activating PTH signaling accelerates some forms of leukemia, like CML, while it protects against others, like AML. So I think that the answer is there will be no broad conclusion. We need to test every cancer individually and learn a lot more about this to understand which patients may even be safely treated with PTH. And finally, I'd like to thank the people who've done the work, my funding sources, and of all of you for your attention.